particularly on I was asked to talk about GI cancer and how we're using PET-CT in managing patient with GI cancer. These are the scary statistics about cancer in general, and on the right side is men, and the left side is women. And if you look at colon and rectum, as well as pancreas is less common, but colorectal cancer is the third type of cancer in men and also in women. As far as cause of death, it's also the third in men and women. And then these are kind of the scary statistics that the lifetime probability for developing cancer by cycling women is 1 out of 3, and colorectal cancer is 1 in 19, pancreas is 1 in 79, and in men, which is even more scary, is 1 out of 2 will get cancer in the lifetime. Colorectal cancer again is the third, and it is 1 in 17. Whenever someone receives a diagnosis of a lesion somewhere, the intuitive questions are, is this a benign disease or malignant disease? And that's what we mean by diagnosis. And if it is cancer, then is it localized or spread? And that's what we mean by staging. And if it is localized or spread, how to treat? Are we treating with the intent to cure, or is it a palliative therapy? And then is the treatment working, or do you need to stop all the treatment altogether? Classically, these questions were just using anatomic imaging. Now it's CT. We witnessed a great deal of development of CT in the last 10 or 15 years, and also because of the wide availability of CT. Pretty much any hospital in the United States will have a state-of-the-art high-end CT scanner in its facility, including even ERs. However, CT has its own limitations. CT will fail to make a distinction between what's benign and what's a malignant disease because they go by size criteria. All they can tell you is that they have a large lymph node, and they've tried to characterize this lymph node, but still size is the main drive and characterization. Whenever you think of CT, you think of a particular part of the body, whether it's a chest CT, or follow-up with someone with a history of lung cancer, for example, or abdominal pelvic CT for someone with a history of colon cancer, for example. But it's not routine that they use evaluation of CT for the whole body. And then, as Dr. Dang said, that there's always a problem when someone starts receiving radiation therapy, for example, or surgical resection for that matter. Differentiating what is post-surgical change versus disease recurrence can be challenging by CT. And then there is a growing interest in the United States and in Europe regarding the radiation exposure as the single most common cause for the international increase in cancer. So we have to be careful. It's not just about money, but it's also about, are we causing cancer in our patients? When patient moves from hospital A to hospital B, nobody even in the United States walking around carrying a card in their pocket, keeping track of how much radiations they are being exposed to. And frequently, when they go from hospital A to hospital B, they have to repeat all the investigations, including all the imaging that took place in the best hospital. Just to put things in perspective, a 10 millisievert per the FDA is enough to cause cancer in 1 per 1,000 in adults and 1 per 550 in pediatric populations because kids are more sensitive than adults. So keep that 10 number in mind. The annual natural background that we are exposed to is about 3 millisievert. Millisievert is the unit that we use to express radiological impact of radiation. Chest X-ray is low on the list. It's 0.02 millisievert, and that's why people feel comfortable to use it literally, and they repeat it as much as they want. There's no radiation is a no-dose threshold, as we all know, so there's no particular, definite dose that's safe. However, on a relative scale, the higher the dose, the higher the probability. So 0.02 millisievert chest X-ray, screening mammograms a little bit higher, is 0.4 millisievert, and that's why there's always a question of at what age would you start having screened mammogram to take the risk versus benefit into consideration. And then CT is significantly higher. Just CT is 8 to 18, abdominal CT is all the way up to 25, and pelvic CT is 10 millisievert. One, for the rest of the state, one big difference between nuclear medicine and any other radiology techniques is that we know how much radiation we're giving the patient because it's strictly calculated based on how much we're injecting them, per milliliter, whatever we're giving. But in the CT world, it's very operator dependent. And it has been published before that even in the United States, we ended up by actually exposing patients to 2-3 times the radiation dose that they intended because of adjustment of the dye. And then what I always like to include in the presentation is the concept over as well. The problem is with the multi-slice CT scanner, now we're talking about 16, 64, and so on and so forth, you have thinner and thinner cuts, which means you are looking at more and more detail in the images. And radiologists are paid high salaries because they are expected to read a large volume. So if they are looking through the images, they have to make, in a split-second decision, a distinction of what is normal physiologic versus what is pathologic. And if structures are looking the same as it is in CT, then it becomes more and more challenging. There are a lot of change that's taking place within the cancer cells, and we can go through the list. But the basic concept in molecular imaging is trying to make a distinction between a normal cell and a cancer cell based on the amount of change that is happening within the cell. The basic concept in FDG is that we're taking advantage of only one, which is increased glycolysis. This is not new, and credit should be given to the German scientists by the name of Werber back in 1930, who discovered that in cancer there's increased glucose metabolism. Everything we do in 2009 using FDG PET is based on this single observation that he made back in 1930. And as you can see from this list in terms of key developments in the PET world, it wasn't until 1982 when we started doing brain tumors and colon cancer, and then 1991 is breast cancer, and then in the late 1990s, it picked up more because the government started paying for lung cancer. So the basic concept in FDG PET imaging is that normal glucose will ultimately get metabolized because of the presence of phosphatase cells in normal cells, the phosphatase enzyme in normal cells. In cancer, you have very few, if any, of the phosphatase. So whatever that is going inside the cell, and in the presence of cancer, more of it will go inside the cell as a result of upregulation of glucose transporters as well as 6-kinase enzyme, but then it will be trapped due to the lack of the phosphatase. That's why you reject anywhere for an hour at least to image, because during that time there's accumulation and trapping of the FDG within the cancer cell. So the benefits of PET imaging are clear. We can improve the diagnostic accuracy in pretty much the vast majority of cancers. We can also improve the staging, because by definition we are looking at a larger part of the body than any other anatomic imaging modalities such as CT or MRI. We are better in assessing the response to therapy, and in many cases we can detect recurrence and or second malignancy at an earlier time point compared to CT or MRI for that matter. We are not going to go into the details of the physics of things, but it's important, again, for the residency to know that we're not imaging the positron, we're imaging the annihilation photons. That is basically a product of an unstable nucleus because of the proton-to neutron ratio. So there's a transformation of a proton to a neutron. In the process, there is the emission of a positron. It travels for a short distance, find an electron, and then undergo the annihilation. So it's all based on Einstein equation of E equal to mc squared. But the key thing to remember, and you'll see that's relevant toward the end of the presentation, is that based on the standard PET scanner, you have a rainbow detector around the patient, and you are detecting something that's taking place along the line of response. But you really don't know if it happens here, or here, or here. Somewhere along this line. And now the diameter of these detectors, we have to keep getting larger and larger because we're getting heavier and heavier. It's 70 centimeters. As Dr. Dani elegantly articulated to you, that it's not a perfect world, and whenever there's a new technology, there's risk to oversell it and then get burned from that. We also have the false positive that increased glucose metabolism is not just a cancer phenomenon. That also happens when there's infection, inflammation, trauma, fracture. False negative, again, you have the BAC or carcinoma, you have multiple types of cancers, whether because of the different nature of a slow-growing cancer such as prostate, or because of the size of the lesion, we may end up with false negative. And then there's the limited spatial resolution because of all the physics represented here, that you are detecting something at a displaced location from where it started. So no matter what we do, it's very difficult to compete with the superb resolution of CT and MRIs as a result of that. And then our inability to pinpoint tumor location in the PET scan and we see a lesion. I remember back in 2002 when we were new to this, you look at a lesion and is it in the supraclav or in the clavicle itself or in the apex of the lung? By PET alone is very challenging. And then we are deadly slow compared to CT. The same vasoskeletal apparatus, 64 slide scanner, will take 15 seconds. It will take us injection and wait for an hour, and then the imaging position, for example, will take another hour. So that's how a lesion or welder will look by PET. You can see a lesion, but it's very difficult to identify the location for the same reason that enabled you to see place, because all the distracting stimuli surrounding information are fading out of the field of view. I should go to David Townsend, the physicist who put the concept of PET and CT together back in 1998 as a prototype in Pittsburgh, and it made it to the cover of Time magazine in December of 2000 as the medical invention of the year. And since then, there has been a widespread dissemination of PET CT scanners throughout the world, and if you have money to buy a PET scanner, you're not going to find it. It's PET CT from this point on. Although it's interesting to note that even in the United States, about 30%, 40% of currently operating scanners are actually PET only, because the reimbursement is the same, meaning people do not collect more money when they do PET CT compared to PET. So the advantages of PET CT are obvious, that you get the anatomic information from the CT and the functional metabolic information from PET in one exam. And then counterintuitively, even though we're acquiring PET and CT images, when you use the CT for attenuation correction, then you are ending by shortening image acquisition, shaving off about 40% because you're using the CT for attenuation correction instead of the transmission scan. Then also counterintuitively, it's actually lower radiation exposure. About 50-60% in the United States operating PET CT scanner are maintaining the CT part as low dose non-contrasting. So it's actually, it delivers about 4 to 5 millisievert. And the PET itself, the simple math is about 1 millisievert per millicurie. So if you have a 3D image acquisition, you're getting about 12 millicurie, then you're going to deliver about 12 millisievert. So you add them together, it's about 17, 18 millisievert, which is less than a single chest contrast study. Just to underscore the concept, you have the power of identification from PET and the power of localization from CT in one example. As far as GD cancer, and from this point on, I'll try to give you examples. It's clear that PET CT is better than PET, and we published back in 2003 at the JNM that using PET CT will increase the confidence in pulling it, and it's better than PET alone or CT alone visual correlation. The sensitivity and specificity is 85 and 67% respectively at the time of initial diagnosis. Frequently, colon cancer will send the assays to the liver. As far as the liver mets, the sensitivity of PET is 88%, which is about 5% higher than contrast CT. The specificity is 96%, which is 12% higher than the specificity of a contrast CT. As far as on the lesion by lesion basis, PET is even better than contrast CT or MRI. In this particular study, it's published in 2005. As far as extrahepatic lesion, the difference is even more. The sensitivity is 92%, specificity 95%, compared to contrast CT of 61% to 91%. Back to the very important concept, it's not about seeing more lesions. As they say in the state book is what are we doing in terms of changing management of the patient? This particular study tried to answer that. It was published recently at the JNM in 2008. Addressing the issue of can changing management and improve prognostic stratification in patients with recurrent colorectal cancer based on a multi-center prospective study. Change the management in 65% of patients with residual structural lesions suggestive of recurrence, and change management in 49% of patients with potentially resectable pulmonary or hepatic mets. So at least 50 to 60% of the time, PET is changing management in patients with colorectal cancer. This is from our studies where our work is a close 63-year-old male who had prostatectomy for prostate cancer, and in preparation for him to have radiation therapy, he had colonoscopy, which was appropriate for his age, which revealed a rectal mass, which turned out to be rectal cancer. Abdominal contrast CT showed no mass, and then the PET-CT was done for staging. So here's the rectal mass, which was known by CT, and it is FPGA. We know that there's nothing new, but here's what's new, that there's multiple tiny nodes. And as Dr. Pang said, that it used to be 1 centimeter as a cutoff, and clearly the third or fourth generation PET-CT scanners that people have, and actually you guys have mentioned now some of these high-end PET-CT scanners, we can push the envelope to 5 or 7, and I'll show you some examples that we've been exploring. So these are multiple nodal disease. And then what's more important or more impressive is that we were able to see a liver lesion that was not seen by the contrast CT. It's important also to understand the limitation of the technology. When you are dealing with a tiny one nodule like that, it may not be FPGA enough, and I never believe in using a particular color as SUV, as Dr. Medhat said. That you need to take things in the context of the disease. So if you are looking at multiple lung nodules that are peripheral, these are metastases by definition, with or without FPGA, given that the patient has already widespread disease. But there was also the incidental finding of intense FPGA-added soft tissue change in the larynx. So this actually ended up by PET diagnosing additional cancer in the larynx, as well as widespread disease, including liver and lymph nodes that were all missed by contrast studies. About esophageal cancer, PET is more accurate than conventional imaging modalities, and per this particular study, which was published in Cancer in 2005, the overall incremental value of PET compared to CT with regard to lesion accuracy was 14%. As far as local metastasis, the sensitivity is 52%, specificity 84%. So all this risky when you read esophageal cancer case, if you have a node as far as esophageal, it will bleed, the lesion will bleed to the adjacent structure, and you will not see the node, not because it's not FPGA, it's because the primary is very intense and the node is just next to it. So we do a little bit better job in terms of distant metastasis, 67 and 97% specificity. This is a 65-year-old male history of laryngeal cancer, had radiation therapy for that, and then presenting to us with a recent diagnosis of esophageal cancer, and the PET-CT was done for staging. With the knowledge of the contrast, the CT showed the esophageal lesion, but no evidence of metastasis. So these are transaxial cuts, PET-CT fused, PET and CT, showing the esophageal lesion. This is just basically sequential cuts showing the top part of the esophageal lesion. And this is kind of the midsection to show you that this is a big lesion, as we saw here. But then, if you go down in the abdomen, there is a definite abdominal node that's FPGA. If you look at the CT, you can hardly see it. I showed this to one of my colleagues in radiology, and I said, just measure it, so I'm not biased. Okay, so you zoom it, and you measure it, and it's 3 millimeters. But that's how it looks by PET. So when we talk about the resolution of the PET scanner, we have to keep in mind what PET-CT scanner we have at hand. And then also we have to take into consideration how remotely active this lesion. Because if it is very active, then it will look significantly larger than its anatomic dimension. That's why we should never put cursor here and give size to a referring position with PET. You give the embolic activity from PET, but you give the size from CT. Because if you play with the intensity up or down, you can make the lesion look larger or smaller. Pancreatic cancer, PET plays a major role in differentiating benign from malignant lesion. The sensitivity range from 71 to 100. Specificity is from 53 to 100. So it's not a perfect cancer for us. It's not like colon cancer. But certainly still, contribution is the range is even wider in contrast CT. So whenever you get some bad news about PET compared to other imaging modalities, you can see that we're not far behind. This is a 54-year-old male with jaundice. Contrast CT showed a pancreatic mass with no lesion, extrapancreatic lesions. biopsy showed pancreatic cancer. They send us the patient for PET-CT for staging. So here's the pancreatic lesion. And this four-phase liver, and the liver was clean in this four-phase study, which is kind of the standard way. Some people now publish that MRI is actually better than four-phase contrast study characterization of liver lesion. But the PET portion of the study showed definite liver metastasis. And again, I'm showing you an example here of lung nodules that by association are most probably malignant, but they are not showing metabolic activity, and probably due to size, so partial bowel effect. Here's a 45-year-old with metastatic adenocarcinoma diagnosed from umbilical mass. So we knew it's cancer, but we don't know where the primary coming from. Colonoscopy was done first and was negative. So here's the umbilical lesions, FDG added, and that was known. But then we PET showed at the tail of the pancreas, FDG ability, but it's totally non-impressive, but did not contrast CT. And this was a biopsy proven, in addition to liver mets. So we took something that was cancer unknown primary and showed that this is actually pancreatic cancer with liver mets as well as metastatic umbilical lesion. These are multiple liver mets in this patient. The GI is also a site for metastasis, just like Dr. Baggy said that in one cancer you have to check the adrenal, and actually we showed a perfect example of totally non-impressive adrenal by CT, but is clearly detectable and highly suspicious for cancer like that. This is a patient with a left upper lung mass. Here's the mass. Clearly there is a large big ugly lesion here in the left upper lung. But the problem is that the PET showed a liver lesion. This is a low dose non-contrast, and the arms are in the field of view by definition radiologists who consider this CT. They don't use the word non-diagnostic. They use that's not optimized for diagnosis. So this is not optimized, but here's the optimized. Here's the contrast for oral, as well as IV contrast continues to be negative. So at that time, the question is it a false positive like that, or false negative by contrast CT? Here's the ultrasound and the legal tract, and this was biopsy proving that's from cancer. So the absence of evidence is not evidence of absence. If you do not see it in the contrast CT, it does not mean that it is not there. It just means that it is there, but it did not cause structural change yet to be detectable by CT. How about additional malignancy? The truth of the matter is the sad fact that when someone with a history of cancer, and they are cancer-free for a few years, we mistakenly may tell them, you know what, 5 years passed, you don't have cancer, you are cancer-free. That cancer may not recur, but whether it's a risk factor, such as smoking or alcohol, or whatever it is, or because of genetic makeup, once someone has a diagnosis of cancer, they're at a higher risk forever to develop a second cancer. This particular study looked into that how frequently we diagnose a second previously unknown cancer. And they said that there's at least 1.2%. The suspected lesion were as high as 4.1%, but the ones that were biopsy proven later on was 1.2%. So at least that is the number. This came out of Hopkins work. This actually came from an abstract that was presented back at ESNMS, and I'm fortunate enough now to have a continuous flow of people coming to work with me in St. Louis, and they're all doing a fantastic job. Whether Salva was one of them, and he presented this for head and neck presentation, but I'm showing you as an example where the patient has no history of head and neck, but then PET scan was done for restation. You can see uptake in the axilla, which were reactive because look at all this big ugly lesion that again, if you use STV, it will be cancer, but actually it's not. The patient had pneumonia, and that's why he has this intense uptake. But there was the accidental diagnosis of totally asymptomatic rectal lesion that was later on biopsy-proven rectal cancer. So patient with head and neck cancer, and then we diagnosed rectal cancer. Clearly, head and neck surgeon would never do rectal exam as part of the head and neck examination. This is an 80-year-old male presenting with a pleural-based right upper lung mass, as well as right hilar node by CT. The patient had no history of bladder cancer 4 years prior, for which he had chemotherapy. So we are discussing at the tumor conference disease and saying, look at the lung lesion, is the chest wall and the ribs involved, and the surgeon are saying, well, but the right panel is involved, probably the patient is not a good candidate for surgical resection. They are saying, well, the bladder, because it depends physiologically taking the bladder, we cannot make a comment about whether the bladder has any recurrence in it or not. And I said, well, wait a second. It looks like there is something else, which is stomach lesion that was later labs proven stomach cancer. So we went from bladder cancer to lung cancer to stomach cancer in the same patient. All you had when you look at the whole body and look globally at the disease. However, it's not without cost, and frequently it's the balance between where you want the sensitivity specificity scale. So we really pet is humbling, and you have to admit when you're wrong, you're wrong. So this particular example is a patient had no history of pancreatic cancer. These are two studies, so this is the baseline, and this is the follow-up. Pancreatic cancer for which he had pancreatic leukodystrophy and partial hysterectomy, and PET scan was done for follow-up. And we showed some lymph nodes at baseline for which the patient received chemotherapy. But this is what we saw, that we saw a focal intense uptake in the stomach. Now, remember, this patient had partial gastric dissection as well. So when it's that focal, we have to hold it, and we hold it, but perhaps it showed that it's stomach ulcer. And this is a follow-up study showing diffuse uptake. So when it's diffuse uptake like that, chances are it's ulcer. When it's focal, you have to hold it, but you run the risk that it could be false positive. But I'd rather be wrong under these circumstances than miss a deadly cancer like stomach cancer. Particularly given the circumstances that this patient has no history of pancreatic cancer before. This is an example of a neuroendocrine tumor of the cecum. Again, this is a baseline study. We didn't have a study prior to the surgical resection. So in follow-up, we detected the rib lesion. The patient received radiation therapy, which resulted in it's not a degenerative analysis, not activity, and the process of fracture in that rib. However, we called it disease progression because we saw that there is a brain lesion. Again, the mesoskeletal archetype, and I know I talked to you about this before, you stop here, you'll totally miss this lesion. The patient is asymptomatic. And we called it recurrence because we saw a focal uptake in the bowel. Bowel can be quite interesting, that you can have diffuse intense uptake throughout the bowel, and you can have one side of the bowel lighting up, typically the right side. And the cecum in particular, because of the lymphoid tissues notorious for having increased FDG uptake. However, given the patient's own history of cecum cancer before, and given that the uptake in the cecum is out of proportion, these are ureters, compared to the rest of the bowel, and given the brain mets, we said this is recurrent with mets to the brain. So here is what we saw, and 2 months later, here's the study, and here's the result. So talking about doubling time, just to refresh your memory, this was the baseline. And in 2 months, this is the patient. But there's always a challenge. How frequently do you use this patient? Are you going to use them every week? Are you going to use them every month? There's no particular guidelines. Now, let alone the whole concept of insurance and the landscapes and what they are willing to pay for and what they're not willing to pay for. We're using PET immediately for responsive therapy as well. This is a 74-year-old female left breast cancer. Bone scan, PET scan for staging. We diagnosed an incidental, totally asymptomatic liver mass in this patient with no breast cancer. And then this was biopsy proven later on, started chemotherapy, and the lesion is gone. So it's a complete response by PET. The patient actually a few years later is still doing well. There's no more impressive way to show the evidence of visualization PET and assisted responsive therapy than lymphoma. This patient has lymphoma primarily the liver. Pretty much the both lobes of the enlarged liver are replaced with malignancy. There's some scattered. There's not abdominal nodes, but the main bulk of the disease in the liver. After the first cycle of chemotherapy, which is 3 weeks from this study, here is the follow-up exam. So here is baseline, and here is follow-up. This is the transaxial cuts showing you the extent of the disease in the liver, and now all of these lesions are burned out. So by CT, there's still some hyperdense lesions scattered throughout the liver, but they're no longer metabolically active. And these lesions may stay like this for many, many years to come. They're not going to disappear. And it doesn't matter what matters, are they metabolically active or not. Also, it's important we are forced as an implementing physician to learn about CT. And I tell you, it's not easy. The older we get, the more challenging and the more difficult it is. And it's interesting, last time I saw that Dan was actually in the CT course, so we are still learning about the CT more and more because you are forced to look at the CT, and whether it's a low dose enough contest or not, you can still rely on the CT to help you because it's not just an FPG PET exam anymore, and then there's also the incidental CT findings that are not FPG added, but they're still very crucial for patient management. This particular study we published a couple of years ago showed an example of non-FPG added renal mass that by CT is very clearly detectable, but if your eyes are trained to just look at the PET, you're going to totally miss it, which is a limitation in renal cancer. Here's an example of a large aneurysm that, again, by PET there's nothing going on, but by CT it's a big ugly mass, and now we routinely look not just for aneurysm, but we look for a thrombus within this aneurysm, because we learned that with chemotherapy you have a higher chance of atherosclerotic and thrombotic diseases in these patients, and we frequently now are training our eyes to identify not just the aneurysm, but whether there's a clot within this aneurysm or not. And we actually caught some cases that were missed by the CT exam. And we don't know the results of the ESNMS this year. It's going to come out in a couple of days. But one of the presentations that we have is the frequency of us detecting aneurysm and a thrombus based on the PET CT. It's another example of using the CT as your savior. If you use the PET, you're going to get cold defects, but by PET you can see that these are plastic lesions. So basically you have about 3% that was published, 3%. But I think in reality the number is more than this, but at that time that's what we reported. This is an interesting case that we saw just a couple of weeks ago that I want to share with you. This patient had a history of melanoma. The good news, the PET exam was totally negative. This is the baseline, and this is the follow-up. Do you see anything that's suspicious here? I don't want to pick on Canada and Muhammad because these are the people who was with us in the state. Right here. Okay, so if you look at the PET, you're going to think it's a rare lesion. What should you do? How about the CT? I'm intentionally not showing you the fusion now. But is there anything on the CT, just go to the CT now, in the area that you said is clear? What's this? What's this? So this is basically, whenever you see a hyperdense, that's a lymphoma. Okay? So the good news is a lymphoma, it's benign here. But the bad news is you start having some soft tissue change within that lymphoma, and it showed FPG ability. Actually, the risk for what? Liposarcoma. So now you look at the PET CT diffused images, and you see that this is not a risk. It's actually within that lymphoma. So if it was with this from the beginning, but the fact that within a few months you had this change of soft tissue within the lymphoma that's FPG added. So just I'm giving you an example that the CT can help you put it together. This is another example of when you are reading PET CT, this is a viability scan. You are legally and morally and ethically are responsible for all the images and how to generate the final image. So this is the final image. So all the cardiologists in the world who look at this, and all of the radiologists in the world who look at this, but diplomats and people should look at this. That's the field of view from which we generated the viability exam. So this patient had a history of heart disease and myocardial infarction and multiple PTCA and all of that. But that part. But that's not the point of the image. The point is, when you review this, you'll see that there's some pleural-based coagulation as well as some retrocrural node. And you look at the metabolic activity, it's somewhat metabolically active. And this was at the edge of the field because of the misfusion. We couldn't see whether this is metabolically active or not. But you really can't judge it because this is a different protocol. Right? This is for imaging the heart, so you're actually you want the glucose to be higher. That is when you are in cancer. cancer, you want the vehicles to be lower. So, but nonetheless, we said, even though this is not optimized, the fact that there is one lesion and the fact that it's relatively active, we're suspecting that something else is going on in this patient. So 3 days later, we did the exam, and here it is, and we found out to be truly symptomatic esophageal cancer in this patient. And the regional pro node is here now, showing mild uptake. How about the patient with no history of cancer at all? Nobody's advocating using PET-CT for screening. However, in Japan, you can get it for screening. It's for business people who can afford to pay for it. This particular study is the only study that I know of that has a large number of patients with no history of cancer doing it just for screening. So the bottom line is that 1.14, so about 1% of patients had cancers that were detected by PET. They didn't have any symptoms at all, and if it wasn't for the PET, they would have lived a normal life till the disease widespread. So the sensitivity in PET in those patients is 79%. Out of those, with regard to the colorectal cancer, there were 220 benign lesions and 102 cancers. Still, the relative sensitivity of PET was higher, significantly higher, than abdominal CT, abdominal MRI, or the serum CA. And the positive predictive value was a different story. So you cannot take one number. You have to take into consideration multiple things. And what matters is the overall accuracy and then the change in management. Now I want to switch gears to what are the new things that are taking place. Well, we have new scanners, new tracers. We have different coverage. That's a big issue in the United States. And in a capitalistic society, everything revolves around money. And then better imaging environment. This is the scanner that we have. It's a Gemini TF with the time-of-flight technology. And it's a 64-slice scanner. And you guys, with Milton Hospital, you have the 16 slice. We have the 64-slice. Sorry? Okay, now increase to 64. That's good. And it has the advantage of the open design as well as the true whole body capability. The Siemens are introducing now the time-of-flight technology to their new scanners as well. But the good news and bad news, whenever you buy, within a couple of years from then, it's time to have the itch to buy something new. So they're competing with each other. Well, the time-of-flight is a simple concept, and it has been around in physics schools for many, many years, but they've not seen the light until 2006, and we were fortunate in San Luis to be the first site in the world in the United States to have it. It's basically, think of it as a very fancy stopwatch that when these two opposing detectors receive the signal, this is at time t1 and this is at time t2, then it calculates very fast that it must start somewhere here. It doesn't pinpoint the exact location, it narrows down to seconds a minute. So you can see that the next generation is going to narrow it down. Now why this is good? One, it saves time. So it's a fast imaging position. Two, that actually can help us get smaller lesion. That's why we can compete in seeing something that's a 3 millimeter lesion or 4 millimeter lesion. And then I'm a strong believer, and I know I shared this with you before about the total body. This is a particular study we're just comparing fluid mucus ulcers where liquid is whole body, but in reality, this is our field at San Luis University, and it's the only true whole body covering head to toe. And does it matter? The answer is yes. Here's an example of a rectal cancer that if you do the reasons called on you start here, but then you would be missing a skin lesion that will be processed with a cell carcinoma. And when we systematically looked at 500 patients, 20 of them had new previously unidentified cancerous lesion outside the mesoskeletal eye. And when we showed the board certified oncologist giving you what would be the staging and management based on the mesoskeletal eye, now show you the whole picture and give you what percentage that will change the management and the staging. And as you can see, that it changed at least in about 30 to 60% of the time, the staging and the management. What's more important is that it's 1% of those 20 patients, 1% of patients had their only malignant lesion outside the mesoskeletal eye. You really need to give someone a clean bill of health based on the mesoskeletal eye, and then the lesion is just at the edge of the field. I know this is the example that I showed you of lung cancer and femur mets. Think of this if this was the only blue lesion and you stop just above it. and then the patient comes back with bad news. If you think about it, in the United States, they do about 2 million scans a year. The 1% is a small percentage, but if you do the 1% out of 2 million, it's not a negligible number. Now, this is an interesting concept that I don't think I shared this with you before. It's the issue of FPG-induced extravasation. So we know that because of its cancer or its therapy, you can have problems with the IV axis for these patients. And what's the most common site when you inject a patient? It's the antecubital fossa, right? And where is the antecubital fossa when you image the head? It's above the head. The recommendation of the ESNMS to have the arms. Just take a wild guess. Very high. What's the highest that you can see with your eyes? Your eyes cannot tell the difference of anything more than 5. There's no blacker than black. So if you change this to 50, it will look just as black. So now it's SUV. So now whatever you're going to say about SUV metabolic activity of these neurons, you will totally underestimate the metabolic activity as well. And people used to make this disclaimer on their books and say, the site which may underestimate the metabolic activity. True. However, they only reported when it is big law. But the size does not matter. It's what matters how intense. So you have to check what is the metabolic activity in that area. So when we took some patients, number one, because now we can see it, there's conversation, it was 11% of patients. And I'm proud to tell you that we have very good technologists. So now the technologist issue is the patient is a difficult state. 11% had extravasation on the injection site. So that means 11% of the SCP that we are reporting are not accurate. And then when we took some patients that they had with extravasation, without and there is no integral therapy, there's no logical reason for the SUV to change. And we looked at 2 points in the body which are frequently used as reference points, mediastinum and the liver. The change in the SUV was 36%. So in the presence of extravasation, you are going to underestimate the metabolic activity by 36% in the liver or the mediastinum. So that means if you are measuring a lesion, you may call it a partial response when in reality it's not, as a result of that. As far as the scanner, the big good and bad news for us is the PET MR, because we don't know. It's a whole new animal in its own right, and we don't know how different the PET MR than the PET CT, how it would contribute, how it would change things. They're going to put us out of business. Do we have to learn MR? I don't know. But certainly it's very exciting. It has the ability to do a whole body. It's going to slow things because you're putting 2 slow image acquisitions, head and MR at the same time. But it's very exciting, but I don't have any example of the literature recently to share with you about PET MR compared to PET CT in GI cancer, but it's a very intriguing new technology. Now remember when we talked about all the metabolic change within the cancer cells, we just said the increased glycolysis, but just like when you do renal scan, you have PKD and you have MAGP, you have different tracers, and depending on the question, you may select a different tracer. It's going to be the same way in imaging. So PET is not FPG. It's basically whatever the tracer that will help you address the question. So there are a lot of other tracers now that are pushing the envelope as far as PET imaging that may have a higher diagnostic accuracy than FPG. Share with you a couple of examples. FLT fluorophanty is actually a marker for proliferation that is being pushed now within the United States to compare it to FPG. This particular study was relatively recently published comparing gastric cancer, FLT compared to FPG. And based on this analysis, FLT reported 100%, I never believe when they say 100%, but at least that's what it's reported. 100% sensitivity, and the FPG PET is 69%. So clearly FLT is higher. But if you look by type, whether it's single grain cell carcinoma or not, in the none, the difference is significant. When it is positive, the difference is more noticeable than when it is negative. So even you cannot just say gastric cancer in general. but you have to go by the subtypes. The same thing for carbon-11 choline. This patient with no hepatocellular carcinoma, you can see the lesion of the CT. FDG is not showing much. The liver is notorious in FDG, especially now with the 3D image acquisition of being heterogeneous, so nobody would be calling this abnormal, but look at the difference in carbon-11 choline. Very clearly seen lesion. So in this particular study, they said it's all about the degree of differentiation. When it is fully differentiated, FDG10 is better. When it is moderately differentiated or full differentiated, then it's actually the carbon-11 choline is better patient to use. So we may end up like having to have 2 studies for the same patient if you're doing it before the biopsy. This is the candidate, one of the most important papers that I know of that was published in the GCO, Journal of Clinical Oncology, reporting the registry. And everyone in the United States is awaiting the results, the verdict from the FDA, which the government should come, the CMS, coming next month in April. Because that's going to change things for us completely. Right now, we have to go by a list of what insurance and government are paying for. The whole argument is that when they established the registry, they collected data from over 23,000 patients and had changed management in 36%, 1 out of each 3 patients. So it goes back to what that is saying in terms of impact. There has not been a single study for CT or MRI to show an impact, such as this one, in terms of the scale of the study and the magnitude of the impact itself. So kind of the study of Matson and some key people are pushing the government, and the government is pushing back. Unfortunately, the data is very convincing, but it's a bad economy time. So money's tight, so we are anxiously awaiting that, which should be released next week. The other key is the imaging environment. I volunteered for a PET scan myself, and I can tell you that I consider myself relatively healthy. But to stay on the bed for half an hour, 45 minutes, is very difficult. Let alone if someone has cancer and you are asking them, don't move, and don't hold your breath and hold the instructions for the telling them. So I'm more and more aware that the imaging rules that we have are actually very unwelcoming for our patients. Whether they are sick, which they're all sick, most probably they have cancer, or because they are claustrophobic or in pain, whatever it is. So this is a really neat thing that I came across, and I'm trying to push very hard in my university thing. It's called ESNMS. It's a company's subsidiary of Philips, that they control the imaging room. It's not about just posting something on the wall or in the ceiling, but you walk in the room, and as soon as you walk in with a click of a button, the whole environment in the room will change. And there's science. It's not a gimmick. It's actually science behind that. Just like when you go shopping at one of the big shopping centers, they control the fragrance and the environment to make you more shopping, to do more shopping. So there's science behind it. And so this is, if a patient is claustrophobic, is a patient in pain, so you change the colors, you change the decoration, you change everything in the room. And I've seen a demo of that, and I can tell you, it's hard to show the slide or two, but it's actually very impressive. And this is more impressive even in the pediatric population. I mean, I know that what you are doing a magnificent job here. It's a very unique opportunity for doing a service that's very needed, as well as a huge opportunity as far as research. The pediatric population makes a big difference, because suddenly you're talking to a 3 and 4-year-old kid and telling them don't move for the next half an hour. Very, very difficult. And your alternative of sedating these patients is not a good one. So controlling the imaging environment and the imaging room is going to be a big thing in the next few years, I believe. I'll stop here, and I'm sorry that I went over time, and I'll be happy to take any questions.